My name is Sandhya Prashad. I am a board certified psychiatrist that specializes in interventional psychiatry, and I'm also the president of the American Society of Ketamine Physicians, Psychotherapists, and Practitioners. Like I said, there were 75 total items, and 73 of the items were is where we reached consensus, and they were organized around 7 different domains. So published evidence base, clinician qualifications and treatment settings, psychiatric evaluation, medical evaluation, safe initiation and maintenance, informed consent and documentation. So some big highlights is that the acute antidepressant effects of IV ketamine is very well established with an induction series of usually 4 to 6 infusions over 2 to 4 weeks, typically starting at zero point 0.5 milligrams per kilo over 40 minutes. That was very, very well established. But there's what we came up with was that there is limited supporting evidence that doses above 1 milligram per kilogram is particularly helpful. So I think that's actually a really big takeaway because you do see quite a bit of dosing variation in the community. Not to say that it's never warranted to go above that, but it really does require some clinical justification and to see if that individual patient is benefiting from that kind of higher dose. So I think that sort of is an important takeaway is just the clinical judgment that is required or that we suggest based on how the patient is actually responding rather than just arbitrarily kind of marching up to a specific dose. And then really very clear that treatment should occur in settings capable of cardiorespiratory monitoring, and that trained personnel is really important. I think that was one of the bigger takeaways is just how much like familiarity and actual training of the staff can make a big difference. People seem to really converge on that. And they did not, another big takeaway is they did not recommend restricting delivery to anesthesia or critical care specialists and thought it just really emphasized adequate medical and psychiatric competence and a team-based model. There were areas that were lacking in knowledge. So I think that's an important takeaway too. And then tracking of the patient. So seeing that they are actually tracking their depression, seeing that they are actually improving, and sourcing from, the ketamine itself from, FDA approved manufacturers when possible. Ketamine should never be delivered as an isolated infusion, that it really does belong within a comprehensive psychiatric evaluation and a very real informed consent process, an ongoing treatment plan. Patients should know that it's a treatment, not a cure, and important like psychological aftercare, and then possibly psychotherapy. And then I think the other big takeaway too is, again, the safety really depends on the right setting and the right competencies. So the treatment team is really, really important. The setting is important. That kind of training is important. So to take very seriously the setting in which you go to. Not, sometimes people, because this is an off-label treatment and it's paid for out of pocket, people will kind of shop around on pricing, but it really is important to kind of find a provider that has experience. I think other than just that, this other expert consensus of mostly academic psychiatrists is going to be published soon as well. And so that really highlights some different areas. So together, they're actually very helpful for the field.